Thanks, Parveen. I'm going to try not to overlap with the other speakers, but I am going to partially overlap a little with Brad, and I've already apologized to him for doing so. I'm going to talk about management of the full thickness corneal and scleral lacerations. I put the lecture together. A lot of this is in all of the word slides are in the handout, just not in the slide form. Certainly, Kristen covered the history and covered the preoperative evaluation. The only things that I'll add to that is that I'm a firm believer with full-thickness corneal lacs, and you're going to go in and try and repair them. I like to have a B-scan. Now, you don't want to do a B-scan in an open globe, but a gentle B-scan, I think, is very helpful because if you end up with a little vitreous somewhere where you didn't think you were going to, you'd like to make sure there's no choroidal effusion or no retinal detachment or something that you would need to have a posterior segment person there. So if at all possible, I try and get a B-scan. The other thing that I would comment on the pre-op is I'm very obsessive compulsive, and I like to do a full exam. But here I have to hold myself back and do not dilate the pupil if I'm taking the person to the operating room unless I'm certain I'm going to take the lens, because you'd like to have the iris protecting the lens. So in this circumstance, I don't dilate the patients. When you get a call from the ER, I usually say, please don't dilate them to try and look in the back if you think we're going to the operating room. I think Chris covered as well the non-surgical management. If you have small, well-opposed lacerations, you can use the old-fashioned pressure patching. It stood me in good stead for many, many years. Bandaged contact lens, aqueous suppressants, topical antibiotics and steroids, and then if you need to, you can use some tissue adhesive. I have not used the new fibrin tissue adhesives, but they're certainly a lot easier to use. They disappear quicker than the cyanoacrylate ones, and I'm always kind of waiting to see. Maybe I'll try it if I have a nice small perforating laceration that I'd like to treat. Patients are better off, for the most part, if their corneas can be managed without sutures. Sutures that we put in, no matter how nice they look, tend to induce astigmatism. Here's a patient who had a nice peripheral self-sealing laceration treated with aqueous suppressants. This was treated with a pressure patch, and it healed. The chamber was deep. The chamber was shallow when we first saw him. The chamber ended up nice and deep. It had a positive Seidel, but responded nicely. Here's one that I think did much better, not seeing us. Came in to see me about 4 months after a supposed injury, had a little lid laceration that had been repaired. Nobody apparently looked at the eye. You can see here that the iris is tucked up into this laceration. You can see this here, and this patient had 20/25 uncorrected visual acuity. So I'd say that this patient's better off than if we would have gone in and put stitches in and other things. But if I saw a patient with this size laceration, I would be taking that patient to the operating room. This patient, there's no question, needs to go to the operating room. And no question is probably not going to see out of that eye. Here's a patient I just showed. This is a slit lamp photo, very bad, but you can see there's a little suture end and crusted here, and nobody looked under the eye. Nobody looked at the eye. I saw the patient about 7 days after the injury and came in saying that their eye was a little irritated. And lo and behold, I lifted the lid, and that's what I found. As well, I found this lash in the anterior chamber that we were able to remove pretty easily. And here's one, the typical limbal laceration that you would want to go and take down the conjunctiva and inspect the sclera. Intraoperative management. General anesthesia, I think, is preferred. I've done a couple of cases under topical anesthesia, which were not pleasant, not easy. I've also done a couple of cases under blunt cannula injection, where I've gently taken down the conj and gone behind the eye, and patients that anesthesia said they would just not put to sleep. I give them all intravenous mannitol. You want to soften the eye. You want to dehydrate the vitreous. It makes whatever you're doing in the anterior segment easier. You want to try to avoid betadine drops. You certainly can prep the lid, but you don't want to get betadine drops in the eye. Do gentle lid prep and draping, etc., and speculum insertion. But what I would say is something that the residents, I try and impress upon them, is when you're there, before you start, get a culture. You can culture the wound. You can burp the wound a little, or when you just give a little pressure, you get some aqueous. So you can send things off for culture. I find that that's very nice. If you end up with an infection after, you're sort of ahead of the game. If you excise some tissue, you can send it to path as well as send it for culture. And all I do is I just use a little culturette. They have them in the operating rooms, and send it off. Intraoperative management, you'd like to carefully match the tissue to establish normal contours. You want to secure the limbus first if the laceration crosses the limbus. And you want to make paracenteses. Now, paracenteses, I believe you can never have too many unless they become confluent. So I think that paracenteses are good. You should make them not the way you're typically radial or how you're used to doing them. Make them so it's easiest for you to get something in to sweep iris out of the wound. So they don't have to be radial. If you're more comfortable with your right hand or your left hand, you should try and figure out how to place those paracenteses. Secondly, when the eye is soft, it's very hard to make the paracentesis, and you end up being much more beveled, much more tunneled into the cornea. So I always tell the residents, try and be more vertical than you usually are, because you never end up that vertical. And secondly, if the chamber's flat and they're phakic, you got a little bit of an issue there, and that's the one time that I'll say, let's go in through the wound and inject a little viscoelastic just to get an area where we can make the paracentesis safely, and then we can go ahead and do what we need to do afterwards. You want to sweep iris tissue out of the wound through the paracentesis rather than through the wound. It's much easier. It tends not to want to come back up. If you're going through the wound, it tends to, as soon as you take your instrument out, it tends to come right back up at you. You want to avoid sweeping across the phakic pupil if possible, because you don't want to damage the lens. You want to avoid suturing the iris into the wound, and I was looking at Brad's stuff, so I'll leave that up to him. And I like to use BSS and or a cohesive viscoelastic to keep the AC formed and prevent recurrent iris prolapse. I like a cohesive viscoelastic because you can actually aspirate it out just with a 27-gauge cannula. You don't have to aspirate it all out, but you don't want to leave the whole AC filled with viscoelastic. Here are some drawings I saw, and this one right here is what I say don't do, because here you can see they're sweeping right across the pupil. And I would say over here would be the better way to do it. You would sweep from peripheral into the center, so your sweep is not going across the pupil. And that's why I say decide which angle you want to make the paracentesis. This is a perfect location to making that paracentesis. Now, if this was your left hand and you were more comfortable, you could make it here, but of course that also depends on the nose. You've got to avoid the nose. But clearly, I'm a firm believer you can't have too many paracenteses. It can make your life much easier. For sutures, I use 10-0 for the cornea. I use 9-0 nylon if I'm repairing the sclera. When I was at Penn, the residents on their skits always would make fun of me because I was always yelling them to go deeper and deeper with their sutures. You always get swelling of the cornea around the laceration, and you tend to get more posterior swelling. So when you look afterwards, your sutures are never as deep as you think they are. There are all kinds of papers describing how best to suture. I think when someone has a corneal lac, the prime thing is to get the eye closed and to match the tissue as much as possible. Sure, you'd like to have as little astigmatism as you could get, but that's not always feasible. So I just sort of try and divide the wound in half and keep going that way. That allows me to keep the chamber formed if I have to repeatedly sweep the iris out of the wound. And you try to limit your sutures in the visual axis. I will make them shorter in the visual axis. And you want to close the wound with whatever works. I don't care how bad the sutures look. If they work, sometimes you get these stellate lacerations that are very difficult to close. You just got to do what you got to do. And here you can see, here's something that I also tell the residents. When you have a beveled wound like this and you're passing your suture, pass it from here to here because you're compressing the tissue against the other tissue when you're passing your needle. If you go from here to here, you're going to open it up more. So I always try and pass my sutures if it's a beveled incision like this. You want to be deep, and this is showing that if you're near the center, you want a shorter bite. If you're peripheral, you can take a longer bite. And here it just says close it however you can get it closed. You want to avoid excising corneal tissue if possible. If you have backup tissue, that's great. There's some vision graft tissue that I'll mention a little later that I was just speaking to Chris. We had talked about getting it and at JHN to have for the emergencies there. But now that we're over here, hopefully it'll be easier to get. And Chris promised he was going to see if he could twist someone's arm so we could have it, just so you have some backup tissue. You want to explore the sclera if limbal involvement. You're always more suspicious if there's subconjunctival hemorrhage or chemosis. And then again, I'm not going to steal Brad's thunder. I don't know what this magic 24 hours, when you should leave it, when not. Clearly, if the iris is devitalized, you're going to remove it. If it's not devitalized, you would always want to try and put it back in if you can. But I'll show you a couple of cases at the end that leave that open for discussion. Dealing with the lens, that's Brad. I talked about using the cohesive viscoelastic because you can aspirate it to remove it. And then the other issues here, Chris is going to talk about when he does his post-operative management. One of the things, the question always arises in the operating room, I always give subconjunctival antibiotics. I always give a light pressure patch over the eye, and I leave it on till the next morning. The question always arises, do you use steroid? You'd like to use subconjunctival steroid to cut down the inflammation, but then again, if you're concerned about infection, so that I usually avoid subconjunctival steroid, and postoperatively for the first day or two, I sometimes avoid the topical steroid as well. Sometimes you like the wound to swell to help close off your laceration site. So here's a typical laceration. The iris has been reposited. And you can see a nice repair with a little air that's still in there. Here, as I said, you get it closed however you can get it closed. You don't care what the sutures look like. Now, here's an argument for not doing the lens at the same time. This is about a week afterwards. The wound looks great here. You've got much better visualization to deal with the lens. And again, I'm going to leave that to Brad. Here's one where you can see this laceration hasn't been repaired yet. And you can see once you're going to have to repair the laceration before you can take the lens. And I'm sure that once this was finished being repaired, the visualization would have been terrible for the lens. So it can't hurt you to come back at another time. And here's the case that I use and I like to show. This is a young boy whose brother chased him into a room. He closed the door. The brother was outside the room. He didn't know if the brother was still there, so he lay down to look to see if he could see his brother's foot under the door, and the brother had a scissors that he stuck under the door. I don't know why he wanted to hit his brother in the foot, and got this nice clean laceration that was repaired. I left the lens because my visualization wasn't very good, and this is about 4 weeks post-op. You can see everything's fluffed up, and it's up against the cornea. The eye's pretty quiet, mild AC reaction. There's no corneal edema. So I sat on it. The pressure's normal. The eye was relatively quiet. I sat on it. And here he is 2 months later. The lens totally resorbed. I went in and I did a YAG capsulotomy, and he's been wearing an aphakic soft contact lens. This was done back when I was at Penn 25 years ago, and he's still wearing an aphakic contact lens and doing well. You try to avoid primary keratoplasty, and you do a lamellar patch graft if there's tissue missing. It's always nice to have some tissue available. This vision graft you can get from Tissue Banks International. It comes in various sizes and shapes. Here you just need any kind of tissue that you can keep. It's medically cleared corneas, sterilized using gamma radiation. It maintains its clarity, and it's stored at room temperature for up to 2 years. So I think that would be nice to have here. And the other nice thing is if you don't use it, after 2 years, they'll take it back and replace it. So it's kind of nice to have available to you. I'm going to leave the postoperative management to Chris. Here's just to show you this is not something that is infrequent when you repair a laceration that you see here. The next day you can get a nice positive Seidel and ignore the phallic symbol there. Okay, this is a patient of mine. Came to see me, sustained an injury 2 days before. I took a look. Took him to the operating room. I cleaned off. It looked like there was a little epithelium on top of that. Swept it back in. It was the inferior iris. I didn't want to cut it out. And here he is a week later. Looks very nice, but there's a little bit of a membrane growing onto the pupil, onto the anterior lens. And this is a little while later. This I took him and did argon laser, applied it. This is what you get when you see epithelial ingrowth, whitening of the tissue. You can see here in the undilated pupil, this is how far the membrane has grown. And now with the pupil slightly dilated, you can see this membrane on the anterior lens. So I took him to the operating room. I did an intracap, cut out the iris. Here you can see the epithelium on the anterior lens capsule. And he's done well, no recurrence. He's done very nicely with an aphakic contact lens, painted contact lens. This I did many, many years ago. Just to show you a different approach, and these are the cases I apologize to Brad for. This is a guy who came in to see me of a graft I had done. I think this case one of the cases I published with Parveen. Is this the one? Okay. This case got published. Parveen, you were a resident or a fellow? Fellow. Okay. Anyway, so this gentleman came in and he had had a dehisced graft wound about a week before, several days before, and he showed up in my office. I took him and I repaired it. I reposited the iris. The iris looked good. I was aware of my other case, so I cleaned off anything that looked like epithelium. And he came back. The graft was repaired, and he had this membrane growing from over the iris here, growing all across the lens. So, I think I could have peeled that membrane. I did peel that membrane off. And the lens is relatively clear, but I took the lens anyway. And I even did a repeat graft because I couldn't be sure if it was on the cornea. And here he is. I did an extra cap. I think I did an open sky extra cap and did another graft. I cut out part of the iris. There's an iris suture here. And here you can see the epithelium growing on top of the iris that I reposited. So I don't know what's the right answer, what to do with the iris. Hopefully, Brad will tell us in his talk. Thank you.